Hello and welcome, fellow student doctors. Today we will discuss triptans, a class of medications that are used to treat headaches, particularly migraine and cluster headaches. Triptans are commonly used drugs and, as such, are commonly tested. Specifically, the boards use triptans to test your knowledge on the pathophysiology of migraines and the role serotonin plays. But don't you worry, by watching this video and hanging out with me, we will get you those points that you deserve on test day. Let's get started, friends. To prepare you for test day, you will be able to 1. Describe the clinical presentation of migraines. 2. Explain triptan's mechanism of action in the context of migraine pathophysiology. And 3. Know the side effects and uses of triptans. To understand triptan medications, you must understand migraines. As background, migraines have a classic presentation on the boards and the wards captured by the A-pound mnemonic. A stands for aura. Auras are commonly visual, classically with flashing bright and dark spots in the visual field. This is called a scintillating scotoma. Auras can also be sensory, with tingling of the face and limbs, auditory with tinnitus, and even motor with speech issues. These occur in 25% of cases and usually, watch this, precede the migraine itself. Hence, the arrows connecting the preceding A to the pound aspect of the mnemonic as auras A precede migraine symptoms, which are captured by each letter of pound. The P stands for pulsatile, photophobia, and phonophobia. Patients describe a throbbing, pulsatile feature of migraines and may report sensitivity to bright lights, photophobia, and loud noises, phonophobia. Want to always remember these terms? Watch this. Patients experiencing migraines often prefer dark rooms due to sensitivity to light, photophobia, as we are now demonstrating on this screen. And if I whisper, it demonstrates phonophobia because people with migraines often prefer quiet rooms due to sensitivity to loud noises. To overcome our own photophobia, let me turn back on the lecture slides. And to overcome our phonophobia, let me start talking in a more normal tone. And we are back. Welcome back, friends. Now, let's continue this mnemonic. The O stands for 1 to 3 days in duration, as migraines typically last between 4 to 72 hours. The U stands for unilateral, as migraines classically affect one side of the head, as captured by the image here. However, you should know that migraines can be bilateral, but are classically unilateral, especially in board questions. The N stands for nausea that can lead to vomiting. Finally, the D stands for disabling, as migraines can interrupt normal daily activities and functioning. So, to recall the features of migraines on test day, use the A-pound mnemonic. Now that you know the clinical presentation of migraines, let's discuss their pathophysiology in relation to triptans. Migraines are thought to arise due to a phenomenon called cortical spreading depression, which is a self-propagating wave of neuronal and glial cell depolarization across the cerebral cortex that is followed by a sustained suppression of spontaneous neuronal activity, hence the depression aspect of the name. Specifically, this wave of depolarization triggers two main events. First, it causes the migraine aura, which is brain site specific. Think about it. Auras can be visual, sensory, or motor, which all depends on how and where that wave of depolarization affects the brain. Also, 75% of patients do not have an aura, which may relate to that wave of depolarization affecting brain regions that are not consciously perceived. Secondly, cortical spreading depression causes trigeminal nerve, or cranial nerve 5, activation and sensitization. This leads to the release of vasoactive peptides, such as calcitonin gene-related peptide and substance P, with the P standing for pain. These mediators lead to neurogenic inflammation, causing pain and vasodilation of cranial blood vessels. This all leads to the clinical manifestations of a migraine. Relating these processes to the A-pound mnemonic of migraines, cortical spreading depression causes the aura, A. Also, cortical spreading depression causes trigeminal nerve activation and sensitization, leading to the pound features of the mnemonic. And if you think about it, neurogenic inflammation causes pain and vasodilation just like any other inflammation, right? Imagine shutting your thumb in a car door. Inflammation causes pain and vasodilation of the blood vessels in your thumb, leading to a throbbing, painful, pulsatile thumb. Youch! Similarly, neurogenic inflammation of the brain leads to the pain of migraines, and the vasodilation aspect relates to the throbbing, pulsatile quality of migraines. Also, let me ask you, how many trigeminal nerves do you have? 2, right? If the cortical spreading depression affects only one of those trigeminal nerves, you get the classic unilateral quality of migraines. That makes sense, doesn't it? Boards may also describe a patient's distribution of migraine pain, like in the picture here, and ask you which branch of the trigeminal nerve is mainly leading to these findings. So, I'll ask you the same. Which branch would it be? Migraines, as you can see, mainly involve the V1 or ophthalmic branch distribution of the trigeminal nerve. To explain the other features of migraines, you must understand this. Serotonin, or 5-hydroxytryptamine, depletion plays a key role in migraine pathophysiology and relates to all the steps inside the bracket. Notably, migraine patients have been found to have abnormal serotonin metabolism in their brains. This results in a relative state of serotonin depletion that predisposes them to migraines. Listen to this because I'm going to blow your mind. In the A-pound mnemonic, N stood for nausea, as nausea and vomiting are common features of migraines. Why is this? The gastrointestinal tract is loaded with serotonin, and vomiting has been shown to raise the level of serotonin in the blood. After vomiting, patients often report the stoppage of migraines. Fascinating, isn't it? Additionally, and this is a key point, the activation of 5-HT or serotonin 1B1D receptors have been found to reduce each of these bracketed steps in migraine pathophysiology. And I bet you know where this is heading. Triptans are serotonin analogs that directly bind to and activate serotonin 1B/1D receptors to reduce the symptoms of migraines. Absolutely amazing, isn't it? Triptans treat migraines. Specifically, triptans reduce trigeminal nerve activation and sensitization, which reduces the release of vasoactive peptides, which reduces neurogenic inflammation, which reduces pain and vasodilation, all of which serve to reduce the pound symptoms of migraines. Yes, pound, not a pound, as triptans are ineffective at treating the aura phase of migraines, which makes sense as cortical spreading depression, not specifically the trigeminal nerve where triptans act, causes the aura. Moreover, triptan medications can be recognized by their common triptan ending. Specifically, the triptan name is based on serotonin's chemical name, 5-hydroxytryptamine. Also, you must know that triptans are serotonin analog that bind to and activate serotonin 1B/1D receptors to exert their effects. Usually, board exams will list them as simply serotonin agonists, and that's why I've made such a big fuss over serotonin. So please focus on that feature. Another high-yield point is that triptans abort migraines. Triptans are rescue medications that are best used soon after a migraine starts. They do not, and I repeat, do not prevent future migraines, and if taken too often, can actually cause migraines, as we'll discuss later. Additionally, triptans are serotonin agonists, and if taken in overdose or in combination with other serotonin agents, can cause the serotonin syndrome, characterized by changes in mental status, autonomic hyperactivity, and neuromuscular abnormalities. Classically, hyperreflexia and myoclonus. Another very high-yield point is that triptans cause vasoconstriction. It is super high yield for you to know that triptans cause vasoconstriction, and as such are contraindicated in vascular conditions, such as peripheral arterial disease, coronary artery disease, cerebral vascular disease, uncontrolled hypertension, vasospastic angina, and pregnancy. In terms of pregnancy, the rich vascular networks of the uterus can be irritated due to triptan-induced vasoconstriction, leading to premature uterine contractions. Overall, I remember this super high-yield side effect of triptan therapy by remembering that triptans activate serotonin receptors that reduce neurogenic inflammation. Inflammation normally causes vasodilation, so if triptans reduce inflammation, they reduce vasodilation. That is, they cause vasoconstriction. Overall, let this image of a heart and its vessels remind you of the vasoconstriction that triptans cause and why they are contraindicated in vascular diseases. Lastly, a recently released drug, lasmiditan, is a triptan-like agent that specifically binds to serotonin 1F receptors and does not cause vasoconstriction. Lasmiditan was specifically developed to overcome the vasoconstriction of traditional triptans, yet still perform similar actions in treating migraines. Triptans, as you can see here, are considered acute abortive treatment for migraines. The acute nature of this refers to the fact that triptans are abortive medications. They stop the migraine. That is, they are reactive, not proactive. Triptans will not prevent future migraines. I repeat, triptans will not prevent future migraines, but will stop the current migraine. Specifically, triptans are first-line acute abortive therapy for moderate to severe migraines, which are simply migraines that interrupt daily activities. Conversely, NSAIDs, or nonsteroidal anti-inflammatory drugs, might be used acutely for milder migraines. Looking at the highlighted text, triptans can be combined with NSAIDs or some antiemetics. However, triptans should not be given with ergotamines, which are also listed in the table. This is because ergotamines and triptans both are serotonin 1B, 1D agonists and can cause severe vasoconstriction, potentially even a myocardial infarction and the serotonin syndrome. Another key thing to understand is that if a patient, in general, has more than 3 headaches a month, migraine prophylaxis may be indicated using the agents shown here in the table. These agents are proactive and prevent future headaches, unlike triptans. You may be wondering, why can't acute abortive treatments like triptans or NSAIDs or ergotamines be used for migraine prophylaxis? Well, the use of acute abortive treatments for more than 10 days a month can lead to a medication overuse headache. It's quite interesting that if you treat a headache too much with an acute or an abortive therapy, you actually get more headache. Man, just thinking about that gives me a headache. Then, a medication overuse headache must be treated by discontinuing the overused acute abortive therapy. That is a commonly tested point, especially in the context of a patient with a pre-existing headache disorder, like migraines, taking almost daily NSAIDs. Lastly, to complete this, you should know that triptans are the first-line treatment with oxygen in the setting of cluster headaches. Note, agents like triptans are acute abortive therapy and are never used for prophylaxis, even for cluster headaches. Time for our flash quiz. The question reads, a patient with a history of migraines is being treated in the hospital for a skin infection with intravenous linezolid. The patient develops a migraine and takes the prescribed sumatriptan, which they normally only use 1 to 2 times per month. What is this patient not at risk of developing? A. Temporary increase in blood pressure. B. Serotonin syndrome. C. Medication overuse headache. The answer is C. This patient is not at risk of developing a medication overuse headache. The patient only takes their acute abortive medication, sumatriptan, 1 to 2 times per month normally, which is much less than 10 times per month, which, at that frequency of use, would increase their risk of a medication overuse headache. In terms of the other answers, the patient may experience a temporary increase in blood pressure after taking sumatriptan, as it causes the vasoconstriction of blood vessels. Lastly, This antibiotic being used, linezolid, has serotonergic actions and, in combination with sumatriptan, could cause the serotonin syndrome. Friends, this was a hard question, so do not feel bad if you missed it. Medicine is challenging, but by taking a small step each day and challenging ourselves with content like this brings us one step closer to our ultimate goal. That is, providing the highest level of quality of care to our patients, which are someone's friends and family members. Keep going, student doctors. We can do this.